Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to What Clinicians Want to Know, addressing current questions and controversies in the management of acute myeloid leukemia. We have a great faculty for this program, Dr. Courtney DiNardo from the University of Texas MD Anderson Cancer Center, and Dr. Mark Levis from the Johns Hopkins University and the Sidney Kimmel Cancer Center in Baltimore, and also Dr. Andrew Way, who worked with me prior to this webinar to record a presentation that will be included as part of this program, and will, when we distribute it, will be included as well. As always, if you have any questions or cases you'd like to run by our faculty, just type them into the chat room and we'll talk about as many of these as we have time. We put out a short 1 or 2 minute pre-meeting survey and also post-meeting. If you take that, you'll get a lot more out of this experience, and we'll learn a little bit more about you. We know a lot of people end up listening to these webinars, and if you're into audio programs, check out our Oncology Today podcast series, including a recent program with Dr. Stein on new agents and strategies in AML. We do webinars all the time. Our last one for 2022 is going to be tomorrow with Dr. Saji Kumar, talking about myeloma and including what happened at ASH. And then when we come back in the beginning of the year, we'll start out with a program on breast cancer, our year in review series with Dr. O'Shaughnessy and Schmidt. And then we'll be doing chronic lymphocytic leukemia on January 5th as part of that same series. And we'll be back again with another year in review program in the beginning of the year on multiple myeloma with Drs. McHale and Nuka. Another one on lung cancer. We're starting up the beginning of the year with a lot of year in review programs, non-targeted therapy of non-small cell. And then we'll be heading out to the GU symposium in San Francisco, where we'll be doing 3 satellite live meetings in front of an audience, but also we'll be putting them out virtually for those of you who want to tune in. But today we're here to talk about AML. Of course, ASH just ended yesterday, so we're going to reflect a little bit on that. We actually did 3 satellite meetings at ASH on lymphomas, CLL, as well as myeloma. And we're using the same approach here that we've used for many of our webinars the past couple years, in that we're going to present a bunch of cases from docs in community-based practice and get the take of the faculty on these cases that we video recorded. As I mentioned, we have 2 lecture programs that we've recorded. One, they're both in the chat room. We're going to send them out by email along with the recording of this program. So really, to get the most out of this, check out the presentation by Courtney and by Andrew. We're going to show some of the slides as we go through today. Basically, we're going to make rounds for most of the time. We have these cases, and then we'll bring up a bunch of recent data sets, particularly at ASH. But before we get started, I just want to sort of take a breath. And we were chatting a little bit before we got started about the challenge of treating AML in community-based practice, particularly for the general medical oncologists. And of course, Courtney, until a few years ago, when we started to see the HMA venetoclax programs, older people, a lot of times did not even get treated or were not treated very intensively. Now, the management of patients with AML who are older is a big part of community practice, but it just came in the last few years. Just kind of curious in terms of those types of patients, Courtney, the kinds of issues that people ask you about, questions that come up, myths or misperceptions that you see in the community.
Yeah, it's a great question. I definitely received many emails and phone calls and text messages throughout the week from community oncologists, directly from, family members, from patients for assistance. And I think, and it's because azacitidine and venetoclax really, as you mentioned, has become the new standard of care. And patients oftentimes are receiving that locally and in their community oncology practice. And the management it's a little bit nuanced, right? And so the questions I often get are, how many days of venetoclax are you really giving? Can you ever stop in a patient in remission? How are you doing antimicrobial prophylaxis, in particular antifungal management? When do you do the bone marrow, and how do you interpret that? I think those are probably the main questions that I receive.
And you're going to see more of that with these videos because they are the questions. Mark, I'm curious for your thoughts. There are patients in the community setting who are younger patients getting managed by general medical oncologists. They don't have insurance coverage to come to tertiary center. You were mentioning to me one of those docs came up to you at ASH and was asking about a case. Just curious again what your observations are, any challenges you see in the community managing younger patients getting intensive chemo.
Well, it's interesting because, in fact, Courtney and I, as full-time leukemia doctors, it's enough for us to keep on top of what we're supposed to do. The faculty in our groups are busy saying, well, which test do we want? The algorithms are getting more and more complicated. Which targeted agent should I do in this circumstance? We can barely keep up with this. So to imagine a community doc who's basically got to now do this intermittently throughout the year, but not very often. It's a huge challenge on top of that. And they know they're supposed to do something. I think the best analogy I remember was like HIV back in the day. You couldn't do much except give back in between infections. And now you would never go near treating HIV because it's so complicated. And it kind of the same thing is really the case with leukemia. It's a subspecialist field. However, patients don't want to come to the big center. They just don't want to. It's big and scary. It's the city, and we still encounter this. So these people. It's not like they want to treat these patients; they have to.
What about the actual infrastructure to support a patient getting intensive chemotherapy, Courtney? Does that exist in these community settings?
It exists to a point, right? But it definitely strains the system. Our patients who are getting intensive chemotherapy and even aza-ven for that matter will need oftentimes blood work 2 to 3 times a week. Oftentimes during that first cycle, they're needing transfusion. So you need to have a mechanism where patients can show up for labs, get results quickly, get a transfusion quickly, which we can do at academic centers the same day. A lot of community practice don't have that blood bank immediate release infrastructure. And then also, especially with aza-ven, getting back to that, a lot of times you're delaying cycles, right? They're in a remission, their counts haven't recovered yet. And so for me, it's really easy to say, okay, we're going to push that week of therapy, delay it a week. But when you have patients that are scheduled months in advance for infusion time slots, it's not actually so easy at some places to do.
Yeah. All right, well, let's get into the real world here. We have a bunch of cases we want to present here today. We're going to start out with an 80-year-old man, newly diagnosed AML, who got decitabine venetoclax. Here's Dr. Olin.
This was an 80-year-old gentleman who had pretty significant comorbidities prior to being diagnosed with leukemia, including atrial fibrillation, COPD, hypertension, diabetes, sleep apnea, and rheumatoid arthritis. But in spite of all of that, he had pretty good functional status. He was fairly physically active and had good social support. This patient was treated with 5 days of decitabine and 28 days of venetoclax during his initial induction cycle. By the end of that, he was very cytopenic, and we did a bone marrow biopsy that showed 3% blasts. We waited for 1 to 2 weeks to allow for count recovery. And then we treated with a more abbreviated course of venetoclax during the second and subsequent cycles. He's actually been in remission for about a year. He's still on treatment. One question is, when using this regimen of hypomethylating agent plus venetoclax, when is the right time to do a bone marrow biopsy to assess for response? Another question would be, how many days of venetoclax should you give? Because the label, is essentially for continuous venetoclax. Do we need to modify the schedule of venetoclax or the dose of venetoclax that's given?
So, Courtney, some pretty basic questions, as you say. Every oncologist is asking this, and I see the answer kind of changing a little bit over time. What's your current answer?
You're right. My current answer for the first question about when to do the bone marrow evaluation, that one is easy. That one's at the end of the first cycle, somewhere between day 21 to day 28. I'm fully comfortable doing it, more like week 3, because oftentimes you'll have that leukemia clearance already, and then you can stop the venetoclax and counts will recover a bit faster, so you can stay more on schedule. So absolutely an end of cycle 1 bone marrow. The next question about, the duration of venetoclax use, that one is really complicated because the studies were designed as continuous 28-day cycles with continuous venetoclax. And so almost certainly you don't need that much venetoclax, but we don't have a lot of data to say how much do you actually need. There was some data presented at ASH that was actually in particularly older, frail, sick patients treated in a French cooperative group, and 7 days of venetoclax actually seemed, with early follow-up in small numbers, to overlap the expectations that were seen with Aza-Ven on the Viale study. So my current answer is we tend to do 21 days of venetoclax with the first cycle because that's when we're doing the bone marrow. I get responses quickly, or evaluations of the bone marrow quickly, can stop the venetoclax. And then subsequent cycles, almost all of my patients end up on 14 days of venetoclax with about 5-week cycles is current average.
So, Mark, Dr. Malady in the chat room asked an interesting real-life question. What if the venetoclax start gets delayed with some challenges in procuring the drug? If it's not you don't start the venetoclax until day 10 or 14, when do you do the bone marrow? How does it change the way you approach it?
Oh, we haven't had that problem, but I can imagine if someone asked me, what do I do now? I would, because there is a synergy with the two agents, and you've just lost that. Monotherapy with venetoclax doesn't work as well. So I would probably say, okay, you've got the drug in hand, reboot, just wait until it's time to start your next cycle of the hypomethylating agent and pretend like you're starting cycle 1. Probably fine, because we definitely would see patients coming in who got monotherapy with a hypomethylating agent that respond when you add the venetoclax. So I probably would say, no, if you don't get the ven in time, do not give. Wait until your next cycle of the hypomethylating agent and then go, would be my advice there.
Okay, let's bring in a couple more cases. Dr. Bacal and Dr. Gupta both have patients with a recurrence to disease and a myeloid sarcoma. Here are the two cases.
He actually ran a marathon not too long after completing his transplant. Unfortunately, a year and a half later, he found a lymph node in his right axilla and a big papule, a red papule on his arm. He had a biopsy, and it actually had the same immunophenotype to his original AML. So he was felt to have relapsed AML that was presenting as a myeloid sarcoma. He was started on decitabine and venetoclax with a plan at that time to bridge to a donor lymphocyte infusion. My questions are, what are some of the new therapies under development for AML that do not harbor a targetable mutation?
Elderly guy with comorbid conditions, but overall stable. He had initially myelofibrosis, then had a transplant done, and then post-transplant he developed extramedullary AML. He has been on azacitidine and venetoclax now for 3 years, doing great. Has had lots of other medical issues with heart, but nothing from the AML perspective. One of the questions that we sometimes struggle with is role of prophylactic antibiotics, antifungals, antivirals, antibacterials. I find that it is not easy to give the full doses of venetoclax or azacitidine.
So a lot of issues there, Mark, in these two cases. Any initial thoughts?
Yeah, with the azoles, we see this a lot. If a patient even is at particular risk for invasive fungal disease on this Aza-Ven regimen, it's going to be during the first month. Usually if they fly into remission and then they're just getting, recurrent therapy, their neutrophil count is not going to drop sufficiently to put them at tremendous risk for fungus. So I almost never use an azole in a patient in remission who's on maintenance therapy with Aza-Ven. I just don't. Unless I'm trying to save money and have the patient can't afford copays and wants to go on 100 of Ven. I've had to do that before. So the azole question, I think, is a real interesting one because there are areas around the country that do not have this invasive fungal problem with induction. We don't. We did not see it in either of the trials. We saw it only occasionally. So we tended to not use azoles. And yet very good doctors I know at places say, absolutely, we see it. So it's a regional problem in part. But you've got to dose reduce if you're in an area where you think there's a fungal problem.
Courtney, any comments on that?
Just two quick comments on that. One is it absolutely there is regional differences, and we live in a swamp, and there's a lot of fungus here, and so antifungal prophylaxis really is quite important because we will see mold infections, we see aspergillus, we see fusarium, ingrown toenails, we see all sorts of fungal disease here. And I would say that the populations that are more prone to develop fungal infections are the patients that have had prolonged neutropenia before their diagnosis that you're starting them on Azaven. So people that have had MDS for a long time, or, maybe diabetes and the things that will affect, your immune system prior. I will also just make a quick statement that, if you don't see a fungal infection, doesn't mean that you don't have one, because they don't grow in the blood as easy as bacterial, infections do. So if you get a blood culture, you're going to have a really bad fungal infection if you're actually fungemic. So you have to have that level of suspicion.
As far as the myeloids,
go ahead.
I was going to say, as far as that myeloid sarcoma, one of the things we would say is essential is getting the genetics on that. And sometimes that's difficult, tricky to maneuver. We're pretty good at it. In fact, our pathologists are now pretty much trained. If they have a myeloid sarcoma, they're busy sending a full panel that they can on it, because you will often have a new mutation that is now targetable in those myeloid sarcomas.
Interesting. Yeah, I was going to say I never visualized MD Anderson being in a swamp, but that's an interesting observation. Anything else you want to say about these two cases, Courtney, and about your approach to myeloid sarcomas, the point about the genetic evaluation? I think Dr. Bacow was commenting on that as well. Anything else you want to say about these cases, Courtney?
I think extramedullary disease is really tricky, and we do see it with it's relatively rare, but these cases highlight the fact that we do see it, and I think genomics is incredibly important. I've been surprised with how effective a hypomethylating agent with venetoclax can be for extramedullary disease. So these cases really highlight the effectiveness there. We also tend to, in patients with big bulky disease, extramedullary, like if they have, chest involvement, high doses of cytarabine, like a cytarabine, can be useful, as well as, radiation spot treatment for residual disease. If you clear off most of the disease, but there's a little bit of PET avidity, we'll involve our radiation oncologist to help with that. But that, of course, doesn't cure the systemic problem. So you can't just do radiation.
So I feel like I hardly ever do a webinar anymore without talking about antibody-drug conjugates, and you guys actually have the original one, gemtuzumab, and we have a patient here, the 39-year-old man, a patient of Dr. Halpern, who received gemtuzumab. Here's the case.
Cytogenetics revealed a translocation 821 consistent with a core binding factor AML. His myeloid NGS panel had a TET2 and a CSF3R, and he was classified as favorable risk disease by the ELN, now 2022. Induction chemotherapy with CLAG-M plus gemtuzumab was initiated, and he obtained a remission negative for measurable residual disease, or MRD, by flow and PCR. And he received post-remission therapy with high-dose cytarabine for 4 cycles and is doing well. My questions for the panel on the use of gemtuzumab would be, how are people using it generally? Are they using it just for core binding factor AML, or for the full favorable risk ELN category to include NPM1? Is anyone using it in intermediate risk disease, where a small benefit was found in studies and meta-analysis? And are people using it with 7+3 only, or with high-dose cytarabine-based regimens? And if anyone is using it as a single agent for relapsed or refractory disease?
Mark, any thoughts?
We use it all the time. So yes, standard 7 and 3, we give it the first cycle just as she was doing for induction. But suppose you have an older person who comes in with, gets azaven, turns out to have core binding factor. We often find they go into remission with an azaven. Their performance status now looks good, and HiDAC is really easier to tolerate than induction with an anthracycline. So we'll often give gemtuzumab with HiDAC as a cycle. In fact, we're doing that kind of routinely. We get them induced with azaven, but then we actually move them to a HiDAC regimen, dose modified. And we use gemtuzumab frequently now for cytoreduction in high white counts. We know that there is a benefit for the use of this drug. It's not harmful in an intermediate risk patient. It's quick, makes the blasts, rather than tumor lice, I think they just go and find a quiet tree to sit down under and die. It's very peaceful. It controls leukostasis beautifully. And so we tend to use it under a variety of circumstances in both favorable and intermediate risk AML.
Fascinating. Courtney?
I think gemtuzumab is a great example of the regional differences in AML therapy right now, because we actually don't use gemtuzumab all that often outside of what Dr. Halpern was mentioning, that the core binding factor patients in particular. So I think, just our strategy is for patients with core binding factor leukemias, which are inversion 16s or the translocation 821s, we will give FLAG, which is similar to CLAG-M, with gemtuzumab. For patients with acute promyelocytic leukemia who have high-risk disease with a white count above 10,000, we'll give a dose of gemtuzumab, because it does, as Mark was saying, very effectively kind of brings that white count down and helps shut off DIC. Outside of those groups, we are not prioritizing gemtuzumab, not because it doesn't add some incremental benefit in favorable and intermediate risk, but because we're really prioritizing venetoclax with our intensive chemotherapy, which is another strategy that is showing augmented responses as well. With the intermediate risk patients, we worry a little bit about gemtuzumab in patients who are going to be going straight to transplant, because there is a small but real risk of veno-occlusive disease. And the favorable risk patients aren't going to transplant, but the intermediate patients may be. And just for any community oncologist listening, make sure not to use gemtuzumab in patients with complex cytogenetics, adverse risk cytogenetics. We know they don't benefit from gemtuzumab.
So, Mark, Dr. Bacow, of course, oncologists are used to targeted therapy. They use it all the time in lung cancer and many other diseases. And yet many of these patients don't have any targets. So his patient that he talked about, a young marathon runner already being treated for relapse, wants to know what's coming what's coming up. We saw some data with magrolimab at ASH. Any speculations about what might be coming up outside of targeted therapy in AML in the near future, Mark?
There are some antibody drug conjugates that are being investigated, CD123 conjugated to drugs. That was an interesting thing. I mean, look at how gemtuzumab is 20 years old or older. We're still learning how to use it in the different ways. And for a while, we got rid of antibody drug conjugates. Oh, they're so passé, we don't want them. Well, now actually, I think that's showing more promise than some of the other cellular based immunotherapies that in AML at least are a bit more problematic. So I love antibody drug conjugates, to be honest.
Yeah, again, we talk about it tomorrow. We're doing our myeloma program. They had an antibody drug conjugate, belantamab vedotin, just got pulled off the market, 41% response rate. We're going to talk about that tomorrow night. But also, I'm curious. Well, you know what? Let's go to this next comment, actually from Dr. Way. So I asked him to suggest a few questions to ask to you two. So here's the first one.
I think it'd be interesting to focus on some of the studies which are de-escalating therapy. We've got all these new therapies, and obviously with doublets, triplets, and all these things that get a lot of press, there is toxicity. And so some of the studies which are addressing this question include, for instance, there's a study from Sylvain Garcia's from France, which is looking at the cessation of Venaza amongst people in remission, addressing the question whether Venaza should be continued indefinitely or whether treatment can be stopped at some point. There was also another French publication which looked at truncating Venaza from 28 days per cycle to just 7 days per cycle. Very interesting data. In fact, almost all the patients in that study eventually went down to a 5-day schedule of 5 days of AZA and 5 days of venetoclax. And so, again, very provocative data as to whether treatment can be de-escalated. I think all of these studies collectively are framing the question, we're getting better outcomes with AML, but can we get those better outcomes with less therapy?
He also referred to studies of trying to de-escalate intensive chemotherapy. I can ask you about that as well. Courtney, there's a bunch of papers that you already referred to, a couple of them, looking at de-escalating HMA venetoclax. Any comments?
Yes, I think the way that AZA-Ven or hypomethylating agents and venetoclax are currently approved is not the optimal strategy for the reasons we've talked about, right? Continuous 28 days of venetoclax is not well tolerated and probably not best for the patient either. And so I do think that kind of a standard hypomethylating agent backbone, 5 days of decitabine, 7 days of azacitidine with venetoclax, probably 14 days or so is probably all you need for ongoing cycles. And that's going to improve patient tolerability. And my suspicion is it'll probably actually lead to improved outcomes because patients are actually getting their assigned therapy, right? They're getting their hypomethylating agent on the backbone that we know is going to actually improve. So over, a 3 to 4 month period, they're getting 3 to 4 cycles as opposed to just 1 or 2 if they have all of these prolonged cytopenias. I don't want to get overly cocky, though, and say people with AML don't actually need any therapy because I worry, 2/3 of patients respond to azacitidine and venetoclax. That means 1/3 of patients don't, right? And so some of these triplet strategies that are adding a CD123 antibody or a CD47 antibody, you're seeing in the earlier studies, right, incrementally improved remissions and hopefully deeper remissions. That's why we talk a lot about measurable residual disease. If you get a deeper remission up front, does that mean that you can then pull back and not need as much in what we would then call an ongoing maintenance? And that is the strategy that I really like. And then you get to the point of if my patient has been measurably, in a remission, MRD negative for, let's say, 6 months or so, could you actually stop? And that would be the population you could potentially think about stopping.
So before I go to Mark with his thoughts, just to come back to you, Courtney, what about the possibility of an all oral regimen, oral HMA? It seems like decitabine would be it's approved in MDS. We know pharmacologically. I'm kind of not understanding exactly why it's not used in AML. I guess you don't really have the data, but you would think it's going to be the same. Seems like it would make a big difference quality of life-wise. Azacitidine seems a little oral, seems a little more challenging. Do you think we're going to get to a point where this is going to be all oral?
I think we will. Yes, it's just a little bit challenging right now because the oral azacitidine is not bioequivalent. You're only getting about maybe 30% or so of the drug, and so it's not the same. So that's oral azacitidine is for maintenance for people already in a remission. The oral decitabine is bioequivalent, as you mentioned. It's approved for high risk MDS. There's a study right now trying to show that oral decitabine with venetoclax is effective and leads to the same outcomes as standard hypomethylating agents with venetoclax. And then I think it will be a very straightforward thing, and certainly patients appreciate the convenience. I will just editorialize a little bit and say that we do see a little bit more myelosuppression and cytopenias with oral decitabine as opposed to IV decitabine, and so that is something I think that the academic community we're still a little bit cautious with the oral decitabine, and that's why we're waiting for that trial.
That's very interesting. Mark, any thoughts? And also, what about the issue of de-escalating intensive chemotherapy? We saw some more data on that at ASH. Where's that?
Courtney will know that I was one of the original de-escalators with AZA-Ven, and I have really am doing more or less the same thing. I didn't like this 28-day thing from the get-go. And the label, the current label for venetoclax is actually causing harm to some degree in this regards. Everybody says, I have to stick with the label. And it's very clear the label is causing unnecessary toxicity. Even in VLEA, we actually had the option of holding treatment until patients recovered counts. Whereas people have it in their heads that they have to start the next regimen on day 29. However, I think we're slowly working our way through this with de-escalation. That is coming, and the label is kind of putting a drag on that. We're de-escalating intensive chemotherapy to a point. I think it's rather don't escalate is clearly the message. Someone told me 25 years ago, we've gotten as much as we're going to get out of intense chemotherapy. You now have to do something different. And unfortunately, over the last 20 years, we've seen numerous trials trying to double it, trying to double the dose of an anthracycline or more cytarabine or more intense. And you really still, the conclusions were continue to be the same. No, we're not going to get any more out of intensifying this. And I'm not sure we're going to get anything more out of intensifying an aza-ven regimen. We know who responds to aza-ven by itself. Now it's time to fold in, to de-escalate some of the aza-ven and fold in the other targeted agents.
All right, let's do another case. This is a 64-year-old woman, a patient of Dr. Battinger, del5Q, thought to be thinking maybe this is a progression from MDS. Here's her, and she's getting aza-venetoclax. Here are her questions.
I actually thought that she would be an induction candidate if she wanted to proceed with induction, but she did not. She preferred to stay closer to home. She does have that del5Q, which kind of is suggestive of maybe a pre-existing myelodysplasia. So ultimately, she started treatment with 7 days of azacitidine and venetoclax. So I was wondering what people thought of that decision versus CPX-351.
Any questions about HMA venetoclax?
I feel like the cytopenias and the secondary complications that occur as a result of the prolonged cytopenias is really the biggest problem that I've encountered with this regimen. Are we still recommending 28 days of therapy, or are we considering maybe 14 days or a shorter duration? At what point would you consider dropping the venetoclax and proceeding with just single agent hypomethylating agent?
Mark, any thoughts about this case and about her questions?
So I hear that the hypomethylating agent by itself and no, that doesn't work very well. We did that for 20 years. No, you have to have the venetoclax. And this is where, again, I sense we're looking at the label too tightly. So we've already, this is exactly the sort of patient that de-escalates. No, I'm not real excited about giving this patient CPX-351. I would have to tell the patient, you're going to be in for 6 weeks. It's a long aplasia, reasonable drug. I have no issues with giving aza-ven, but here is where kind of the familiarity and practice comes in. No, this patient gets 21 days from me. I'm already checking a marrow on day 21, looking to stop that ven and spacing things out. So the cytopenias are utterly manageable when you're willing to de-escalate quickly, or rather when you're familiar with the regimen. As we've discussed, quickly get that marrow, assess that blasts are cleared, stop the ven. And I don't like the idea of de-escalating to AZA alone.
Mm-hmm.
Any comments, Courtney, about the case or about Mark's thoughts?
Yeah, so I think the other thing that's really important to think about in a case like this is this patient is 64, right? And this patient has, intermediate to actually adverse risk disease with that RUNX1 mutation. So we can do a CPX-351 intensive induction. We can do an azacitidine venetoclax lower intensity induction. We can get this patient into a remission with either approach. And this, the aza-ven is perfectly appropriate, but we need to be thinking about a transplant in this patient, because if we chose the aza-ven option, the patient's going to do well for a while, but we know the median, overall survival in patients with monocytic disease like this, with signaling mutations, it's going to be about 12 to 15 months. So this is a patient that absolutely get them into a remission, but be thinking about a transplant. And in the original Aza-Ven data, we weren't taking people to transplant because these were the really older, unfit, frail patients that weren't transplant candidates. But now we're seeing how effective it is, and we're moving it into younger patients. But those are the patients that we don't want to not give them that option of a curative transplant.
And that is a debate, though, because you could arguably get, at least from what we've seen with MRD, you don't get quite as deep a remission with Aza-Ven as you get when you pound somebody with CPX-351. So I would have some second thoughts about maybe should I give CPX to this patient. I probably would still do Aza-Ven and still try and transplant.
Okay, so I want to pick out a few slides from your presentation, the two presentations that go with this program. I don't know, just to give us a little break for a minute or two from the cases, and we'll get back to the cases. So, Courtney, this is a paper you reviewed in your talk, and you, of course, have done a lot of work in this area, adding Ven to intensive chemo. Can you kind of summarize where we are right now with that really exciting thought?
Yes, and so this is a slide from a publication that we did where we pooled all of the different trials that we had where we've added venetoclax to our intensive chemotherapy frontline backbone compared to what we were just doing with standard intensive chemotherapy just a few years earlier. So it's, comparing and contrasting, and we can see, patients where you add venetoclax to intensive chemotherapy, we are seeing more MRD negative remissions. We are getting more patients to transplant, and that was most pronounced in patients with intermediate and adverse risk disease if they were P53 wild type. There is a subset of adverse risk disease patients who have P53 mutations. Those patients don't respond to venetoclax, and there's really no utility in adding venetoclax. But outside that, that's where we saw the benefit. And I'm of a bit of two minds when I present this data for CME purposes, because this is data from from the MD Anderson. We are an academic center where we are monitoring these patients like crazy. We're getting labs 3 times a week. We're giving transfusions. We're giving 3 different antimicrobial, an antibacterial, antifungal, antiviral. We're super cautious. And so this is a more intensive regimen. And so that is always the caveat to the improved outcomes that I'm showing here.
So I might
Mark, any thoughts about
that now, Courtney, what about removing the anthracycline from your intensive regimens and just substituting Ven? This is anathema, perhaps, to the more is better. But a lot of the toxicity comes from that anthracycline. I really wonder if we couldn't get almost the same bang for the buck, spare the patient the tissue damage that's going to cause problems in transplant.
Yeah.
So I would, high-dose cytarabine, as you know, cladribine, cytarabine, not anthracycline, along with the addition of Ven. Just substitute.
Yeah, and that's essentially what I completely agree. 70% of patients went to transplant, usually within 2 cycles. So they're not getting multiple cycles with anthracycline. But if you were not taking your patient to transplant, I fully agree that you're giving the venetoclax, so kind of a flag Ven as opposed to a flag Ida Ven,
I think the anthracycline is what's going to cause the tissue damage and will cause morbidity during the transplant. I actually would, as you know, I'm the ultimate de-escalator. I don't believe more is better. So I would be looking to get rid. I hate those red colored drugs, man. I hate those things.
Why don't you just say what you think, Mark, Just kidding. Okay, a couple more recent papers, then we're going to get back some cases. Courtney, you referred to this, the update of the Viale A study of Aza venetoclax. Any thoughts about what was seen there?
Yeah, I'd be interested in what Mark has to say here. Because the median's the same, of course, as the original publication, because we'd already met the median survival. And the long-term follow-up shows the continued benefit of azacitidine and venetoclax, which is great. But, a couple of years ago, we were hoping that aza-ven was going to be a curative strategy for a lot of patients. And the downside to the long-term follow-up is we're not really seeing a great tail to that curve at like 30 to 40%. And so it confirms patients do great. And better than AZA alone, but most people are not cured.
Some of those
also,
patients, those little tick marks are my patients. Actually, one of them I transplanted. Yeah, one of them I transplanted, and one of them I stopped therapy. He died 2.5 years later of unrelated medical issues. He's like 85. He was off therapy for 2 years.
Wow. Courtney, another paper you went through in your talk was this one from the JCO, Keith Pratt's, looking at MRD and VIALE-A. What was the message here?
The message here is that patients who obtain flow cytometry MRD negative status are those patients who have improved duration of remissions and an improved overall survival. So that's shown in the curves that you can see now. That blue curve are patients who are responding and also become MRD negative, as opposed to the orange curves, which are those patients who obtained a remission but never became MRD negative. So it's just kind of getting to that next level of remission and durability of remission by clearing disease. And so it is something you can use to identify in your clinic who is more likely to have a more durable response.
Another thing you reviewed was this, looking at GCSF in VIALE-A and VIALE-C. Again, what was the message that comes out here? It seems like it's a pretty reasonable strategy.
Yeah, the message here is that, we were all taught as fellows and medical students that you didn't want to use GCSF for patients with myeloid malignancies because you're going to stimulate the blasts. And the message here is that, we know venetoclax causes on-target neutropenia. And in patients who are already in a remission and you've gotten rid of their leukemia, can you use GCSF safely like you do in other cancers? And yes, here it shows that you can. You have shorter periods of neutropenia. You have less days of neutropenic fevers and infections. And actually the outcomes were, if anything, better when in those patients who received GCSF. So it's a safe and appropriate strategy.
All right, let's get back to some cases here. Mark, I'm curious to hear what you think about these two cases. This first is a young patient, 50 years old, with MLL mutant disease, and the second is a 72-year-old patient with IDH mutant disease. Here's Dr. Kyriakis.
50 years old male who had past history of esophageal cancer, treated about 5 years ago. He did well with chemo radiotherapy. Now he's coming to clinic with pancytopenia, and doing a marrow on him showed therapy-related AML. The patient had MLL rearrangement. Now, would you consider CPX-351 on this patient? And would you do it outpatient versus inpatient? For patient with AML with MLL rearrangement, what's your thought on menin inhibitors in terms of efficacy and toxicity?
Given his IDH1 mutation status, would you incorporate IDH1 inhibitor abocitinib in his therapy upfront? Given his excellent health, he's 72 years old, would you treat him with CPX-351? Would you give him 7+3? Would you give decitabine or azacitidine and venetoclax? I would like to know how they decide how to treat somebody that's de novo versus with an underlying myeloproliferative disorder.
So, Mark, why don't you start with the first case? This patient had a history of esophageal cancer, got chemoradiation therapy, now has secondary AML with MLL rearrangement. Any comments?
So this is a terrifying disease. It's incredibly aggressive. It's associated with a lot of DIC, very difficult to treat. Yes, I would, without hesitation, pull out CPX-351 in this circumstance. And the patient's being typed for transplant the first week with the idea, would I give it as an outpatient? No. I recognize it can be done. I'm firmly opposed to this. I suspect MD Anderson is also. We like to keep our patients. This is not chemo light. This is a deep, long aplasia, and you can get all manner of things. Patients can sit the entire month and read a book and look like they never got anything. Totally see that. And sometimes you feel, gee, why did I keep the patient here? But I'm just about to discharge somebody today who had everything, seemingly go wrong. He's leaving with a biliary tube. He's fine. I'm going to transplant him. But in fact, you really have to be prepared. This is intensive therapy. So that's, we would admit, I would give CPX, transplant would be lined up.
What I've heard people talk about is giving the CPX as an outpatient and then for insurance reasons, and then admitting them once they need to be admitted, I guess more for practical consideration. What about menin inhibitors? Seems like there's 1 million of them, Mark. Do you see them coming into practice? And if they do, what's it going to be like to use these drugs?
Well, they are going to get approved. I think Courtney and I would both place heavy bets on that because they fit the paradigm of all of our targeted agents, hitting a driver mutation, getting a differentiation syndrome, getting early prompt responses. Right now, we're still working it out, but obviously there's a Syndax drug that's probably going to cross the finish line, not in the not too distant future, at which point we're going to immediately want to fold that in with intensive therapy and give it as post-transplant maintenance, which they're doing right now in patients who are bridged to transplant on the Syndax drug. It's a very effective therapy. The response rate is still 1 out of 3, something like that. But they're coming, and they're going to be a part of our therapy for these patients in the not too distant future.
And what's going to be involved from the point of view of toxicity, Mark? Is this something that can be done in the community?
In the setting, when you combine, in the relapse refractory setting, if you give an agent like this, or if you give an IDH inhibitor to a patient, or if you give a FLT3 inhibitor to a patient, you can get a life-threatening differentiation syndrome that can require some expertise to manage, and it can be quickly lethal, particularly in the cases of these menin inhibitors, it would seem. I'll bet when you fold this in, if you debulk the disease with chemo, you're not going to see that problem. And so I'm not so panicked about this in the future as we're folding this in early on in treatment. But certainly in the relapse refractory setting, differentiation syndrome is a scary thing, which you've got to be prepared to deal with.
Yeah, we actually have a patient we're going to present in a second with that. What about the second case, Courtney? We know IDH mutant AML is very responsive. HMA venetoclax, this man's 72. He could be a candidate for intensive chemotherapy. How do you approach the use of IDH inhibitors either way in the younger and older patients?
So I'm starting to really think there is a difference between IDH1 and IDH2 mutated patients when it comes to AZA-VEN expectations. And the IDH2 mutated patients are the ones who are the longest responding patients, deep MRD negative remissions. And so if I have an IDH2 mutated patient, I'm perfectly happy to just put them on AZA-VEN frontline if I don't have a clinical trial of a triplet, for example. IDH1 is a little bit different. The expectations with IDH1 mutated patients getting AZA-VEN, you get about 2/3 of patients responding with a median survival of 15 months. That is exactly overlapping with the overall population. And so they do well, but they don't do exquisitely well. And so the challenge with an IDH1 mutated patient is we also now have the approval of azacitidine with ivosidenib, the IDH1 inhibitor, in the upfront setting with composite remissions that are a little bit less, like 55 to 60%, but a survival of 2 years now in that randomized study. And so there you have two different options. If all things were equal and you knew the IDH1 mutation status up front, I kind of prefer the AZA-IVO IVO because you don't have those myelosuppression, cytotoxicity, infection problems. The challenge is that in most community practices, it takes usually 2 to 3 weeks to get your NGS testing results back, and you've already started the azacitidine and venetoclax. So it would be great if, as a oncology community, we could really focus on getting targetable mutations back within just a couple of days.
And this patient was IDH2 mutant. Mark, anything you want to add to that?
Yeah, I mean, IDH1, Courtney and I both have patients that are on IDH1 inhibitor only, ivosidenib, that are alive in remission years out with that as the only therapy. I don't have anybody like that with IDH2 inhibitor. And IDH2 is a different disease. It tends to present with an MDS picture, often with an SRSF2 mutation. They're both indolent. You actually do have time. And it's a good point how these indolent AMLs, these older patients wait. You actually can wait and get your genetics. You don't have to jump the gun on AZA-VEN instantly, because absolutely I will reach for the AZA-IVO over AZA-ENA. Or I'm sorry, AZA-VEN. I don't use AZA-ENA at all.
Yeah. Same.
Really amazing to me, sitting back and listening to people over the years, how things change. I remember it wasn't that long ago. It seemed like IDH1 and 2, I couldn't even separate them out. Now more and more I'm hearing comments as what you just mentioned. I want to get your reaction to this next case of a 70-year-old man with recurrent IDH2 mutant AML, pretty advanced disease, gets anacetinib and develops a differentiation syndrome, but also is thought also to have disease progression. Here's what happened.
He was started on enasidenib. A month later, he came back with increasing leukocytosis up to 82,000, monocytes of 88%, hypoxia, pulmonary infiltrates, and altered mental status. This was felt partly due to differentiation syndrome and potentially an element of progressive disease as well. He was initiated on steroids, as the white count was rising. Enasidenib was continued. And so I guess the first point of discussion is how best to monitor these patients when they do go out into the community. And, I think steroids were added as the white count was increasing here. Would people have held the enasidenib, or would they have just started hydroxyurea to try to curb the rising white count?
Mark, any thoughts?
Well, holding the enasidenib, as we know, isn't going to help because the drug has a tremendously long half-life. So it's going to be there for the next few weeks, no matter what. So we don't routinely hold it. And as far as managing these patients, I always tell them, you're not going to know the symptoms. Something will be wrong. You'll sense something wrong. And you pretty much, I carefully follow, even when they're in the community, I order labs with LabCorp or one of the firms that will, commercial lab testing things, whoever they are. Even if they're being followed locally, I can put in orders and they go to the lab once a week just so I see and can see what could be going on with differentiation. So I'll give that patient a call saying, what's going on? I need to get you in. So I tend to try and follow them because I think weekly labs at a minimum for these patients are essential to pick up this differentiation syndrome. And letting the patient know it could be anything that you could be feeling, that's something's going wrong. Courtney's anxious to talk.
Yeah,
I was just going to add and say, I'm sorry. Yeah, I was going to say that you only know you have differentiation syndrome in retrospect. So Mark's point is really important because in a relapse patient, they could be progressing, they could have an infection, or they could have differentiation, or a combination of 2 or 3 of those. So just the most important thing is start steroids. If your patient has, a culture negative fever or infiltrates or effusions or edema, anything that could potentially be differentiation syndrome, 10-BID of dexamethasone to start.
So actually, Dr. Rudolph, who presented one of these cases, also in the chat room, wants to know, would you ever use preemptive corticosteroid dexamethasone to prevent differentiation syndrome, Mark?
No, it's not frequent enough to warrant that. I think you'd run into problems with these patients for the usual steroid problems. So no, I wouldn't. It's easy to pick up if you're used to it and you are vigilant.
So, yeah. Let's go back to Dr. Wee. This is the second thing I asked him if he had any specific questions he wanted to throw out to the two of you. Here's what he had to say.
Mark, being one of the world's experts in FLT3 abnormalities, I think you should ask him the question, should you use midostaurin, gilteritinib, or quizartinib in frontline AML? Second, you should ask Mark, in patients with relapsed and refractory disease, should we use gilteritinib in combination or a single agent? I think I know what the answer there will be. And Courtney DiNardo, my question is, do we need triplets for IDH mutant AML, or should we just use Ven/Aza and reserve the IDH inhibitors for relapse, or vice versa?
Any questions you have for Courtney about Ven/Flag/Ida?
Yes, it's a very effective regimen, but it is also very myelosuppressive. I think 7 and 3 needs to be addressed first before we go to Flag/Ida, because if we can't do 7 and 3, there's no way we're going to do Flag/Ida, or we shouldn't do it if the toxicity is going to be excessive. But very interesting area, randomized trials, carefully conducted, will be required to answer these questions scientifically.
So, Mark, any comments about his questions for you?
We're always tempted to go to the shiny new drug, whereas we wrinkle our nose at the first generation. But in fact, so he's talking about midostaurin, which is the older drug, gilteritinib, the shiny new one, and quizartinib, the even shinier newer one, which actually is technically older, but regardless. The problem with these newer drugs, when you fold them into intensive chemotherapy, they have a long half-life, and the myelosuppression is genuine. We're just about to publish on this. I could actually not be surprised if it's better to induce with midostaurin. It's a short half-life, get the patient in remission, and then transition them to one of the newer agents during subsequent therapy. It's beautifully tolerated when the patient's in remission. The myelosuppression is real, almost certainly caused some deaths with quizartinib when folded into induction chemotherapy, and is delaying count recovery and remissions with gilteritinib. So Andrew knows full well this is not an easy question, and he's patient and is going to wait for trials to guide us in this.
Really interesting. What did you think about the Quantum study, the phase 3 trial presented on quizartinib, Mark?
Well, I find it interesting that it didn't benefit people over age 60 because it had a backbone of intensive 7 and 3, and all we do with that is put people in a wheelchair. Good news, you're in remission, but sadly, you're too sick to get any further therapy. And that's a problem, which is why we're going to have to figure out how to use an Aza-Ven backbone for those patients with this FLT3 therapy. But the Quantum First data overall are, of course, quite exciting. I think we're going to get a new FLT3 inhibitor to use. But now it brings up the whole conundrum of, well, which one do we use and when? And it's going to cause just total chaos in the field. We're going to have 3 inhibitors soon enough to decide which one to use during induction.
Just out of curiosity, if you have quizartinib and midostaurin available, what would you likely do?
For a younger patient, at this point, I would still do quizartinib without hesitation. But again, you could think about ways in which you should mix and match. Midostaurin goes away the instant you stop it. Quizartinib hangs around for 2 weeks. And there is real myelosuppression that is seen there. So it depends on the circumstances. I'm not sure the answer is quite as clean as we might think.
So, Courtney, any... I know you're the first one who told me about how patients hate midostaurin because of the way tastes and smells.
Smells.
Courtney, Courtney, any thoughts? You already talked a little bit about IDH. Any thoughts about his questions for you? And also the question of Ven/Flag/Ida.
Yeah, I mean, we talked about the Ven/Flag/Ida a little bit already, and I agree with him that, it is an intensive strategy. You actually don't have prolonged myelosuppression the same way you do with Ven/Aza. Actually, patients recover faster. Count recovery happens faster with Flag/Ida-Ven than it does with Aza-Ven, with the average time to count recovery of just 35 days, which is 5 weeks, but it's not 6 or 7. But I think it really is something that is done at major academic centers. And if we did a randomized trial where it was, fly-guided is being used throughout the country and the world, I would be nervous that it might be too toxic. But at places where you can give it effectively, I truly believe it improves remission rates and potential cure rates. The question he was asking about triplets for IDH1 or FLT3 for that matter, with azaven, gilteritinib, azaven, ivosidenib. I think the important thing is when we talk about triplets, we're not talking about continuous 28 days of venetoclax. You can't do that with a doublet. You're not going to be able to do it with a triplet. You're giving the azacitidine or decitabine for that matter. You're giving 10 to 14 days of venetoclax, and then you're giving the targeted therapy, oftentimes at a lower dose, like with the gilteritinib one that Dr. Chort presented at ASH. It's azacitidine, 14 days of venetoclax, and 80 of gilteritinib. And with that, we're seeing really nice, deep remissions. The question, though, is going to be long-term durability, and does that actually improve overall survival? And that's going to have to be proven in randomized trials.
So I recommend the audience to check out Andrew's talk, reviewing a lot of these papers and much more. He didn't have this T-shirt in here, Mark, that you sent to me. I want to know how to get one of those. I guess, what is that? Is there an advocacy? Is there a FLT3 advocacy group?
No, LLS, I would imagine, but I don't know. That's a very old slide.
All right. Well, in any event, I want to thank both of you so much for joining us today. Audience, thank you for attending. Calling back tomorrow night, we'll hear what Dr. Kumar has to say about why Belamaf is no longer available. And also, I'm really curious to hear what he thinks about the big determination paper presented at ASCO on transplant. Be safe, stay well, and have a great night. Thanks so much, Mark. Thanks, Courtney.
Thanks, Neil.
Thank you.
Bye, Courtney.
Take care.